a little tired.
He said I'm here and he's a little tired. So what's going on? You know,
Oh,
I know I call you on the phone and I'm like, are you okay? Yeah, I'm just busy. What you got? So anyway, June is the month for men's health. And we're going to talk about that today. We're going to talk about men's health. We also have our other favorite person here, Deb Nevels. She is the manager at the Milwaukee Community, the Medical College of Wisconsin. I'm trying to get it right here. I'm moving you around, yes, but we are talking to the Milwaukee community today. And Deb, she really does a lot when it relates to men's health and with her program, as far as looking at prevention for prevention and cancer. And so we're going to have some really special guests here today to talk about that. So good morning, Deb. How you doing?
Good morning. Thank you for having me at the table this morning.
At the table. We at the table.
That's right.
Yeah,
We're
we
gonna
are
talk
at the
about
table.
no shame in the game.
No shame.
Ooh, and I wonder
Men's
why
health.
we're saying that because I know that's been a challenge for so many of our men as far as looking at their health and getting their prostates checked, and so we're going to dive into that today as we kind of move forward. Dr. Izzard, what's been happening on the research area when it talks about prostate cancer and
Oh,
what's
man.
going on?
The big thing I think that's on everybody's mind right now is Joe Biden being diagnosed with prostate cancer. How did that happen? I mean, this
Right.
is someone who's probably had some of the best health care available, in the United States. And and actually, I've been looking at that, because my first thought, like a lot of people's thought, was, wow, he's had prostate cancer and hasn't told anybody. We kind of all go to that kind
Yeah,
of
that's what we
place.
were thinking because I was kind of thinking that too because he gets a physical every year.
Right, right, right. But you know what? And this actually kind of highlights some of the limitations as to what we know about prostate cancer, and we've been saying this all along. Um, so uh, there's an organization called the U.S. Preventive Services Task Force, and they make recommendations about screening tests. So they make recommendations about doing mammograms and Pap smears and colonoscopies and prostate cancer. And so they recommend that if you're after age 70, that we should not screen guys for prostate cancer anymore because the vast majority of these cancers are slow growing. And if you find a cancer after 70, the chance of a man dying from prostate cancer is less than the chance of him dying from something else. So, and if you do screen and you find prostate cancer, well, then you're kind of left. Well, what are we going to do? And a lot of those guys end up with surgery, and they're more likely to have problems, complications from the surgery. So, when you look at the benefits of screening versus the harms of screening, the harms outweigh, at least according to the task force, the harms of screening outweigh the benefits. And so as I think about it, I said, you know what? He's 82 years old. So probably what happened was he probably never got screened again for prostate cancer after turning 70. So it could very well be that it's been 10 years since he was screened, and that's why it has metastasized.
I was thinking about that, and I was like, I think that shouldn't they look at the age of the likelihood of people living like in their
Yeah.
80s or whatever?
Right.
And so, it's kind of interesting because I know a person that went for screening and they were saying, well, you're getting close to 70, so you probably, we
Mhm.
wanted to check that.
Right.
And then they're like, well, your grandmother lived to be about 100 and your
Yeah.
dad is 97.
Yeah.
So, maybe
Yeah.
we should get you checked too because
Right.
you have a likelihood of living longer.
Right. And see, and that's where the research comes in because you know information changes. People change, so people are living longer. So people who were of your parents' generation, the average life expectancy was 65 years. Now, people, and now right now it's 72 for men, and I mean by time, but that's for for people at the age right now. But by the time the kids who are being born now, they might live to 100 years. So
Wow.
so
Wow.
those guidelines have to change, and the only way to change them is to do studies. Find out how many people are getting these prostate cancers, and then what's the best, and also screening too, because that's the other issue is the screening good? Does the screening work? Are there better tests? And again, as technology changes, we get better tests. And right now, we're screening for damage to the prostate, in the form of elevated prostate specific antigen or PSA. Um, but maybe there's a better test. Maybe there's a genetic test we should be doing. Maybe
Mm,
there's other things that technology as
right.
the technology changes that might be better. But again, all this is all research.
And that's something that when we start looking at research, and I was thinking about Joe Biden, especially because they mentioned that his cancer was one of like a really
Right,
aggressive
right,
cancer.
right,
And so when I was thinking about that, so maybe he didn't have it as long.
right.
And
It could be, and we don't know. Yeah, maybe he hasn't had it for 10 years. Maybe it just popped up recently, the last couple of years. And it's not, all the realm of possibility for someone to have, an aggressive form that that spreads very rapidly. That it's yeah, it's very tragic. The problem with anytime we're talking about making policies, you're looking at this U.S. Preventive Services Task Force. They're making recommendations about how to screen the country.
Mhm.
And so you're looking at odds and chances. And so if you're over 70, the chance of you having prostate cancer, is you have a certain, odds of getting something. And then the you're looking at the chance that it'll be aggressive. When you say chance, that means that there are people that are outside of the average. You got some people on the low end, some people on the high end. And so what applies to one person may not apply to everybody and vice versa. So, when we say that guys after 70 should not be screened, well, there may be some men up to 70 who are 70 years old who are very, very healthy.
Right,
And so
exactly.
right, and so I mean it's always up to the provider, to go outside the guidelines. But there are a lot of things trying to keep you in the guidelines too. So whoever you work for, they're looking for you. Are you following guidelines? If you have a lawsuit, they're going to ask, well, did you follow the guidelines? So
Mhm.
these recommendations are made for a reason, but they don't necessarily apply to everybody.
And when I was looking at some of the data related to this, they were saying that 6 out of 10 men ages 65 and older are diagnosed with prostate cancer. That's over 50%,
Oh yeah, yeah, yeah. Um, so if you live
especially
long
with
enough,
African
right, right. If
Americans.
you live long enough, there's a good chance you'll get prostate cancer. One out of eight. But um,
So,
it's
doctor, I'm just thinking about, what if that's the case, is the likelihood is almost like, you know, 6 out of 10.
mhm,
So basically, we're going to also talk a little bit more about what we can be or do to be more proactive with that, to
mhm,
be preventative. And I know, Deb, you're going to be kind of talking about that as well because with your program, you work with that.
mhm,
Yeah. One of the things, and just going back on what Dr. Isser said, is understand that there is a tight window that the USPTF gives us for prostate cancer screening, 55 to 69. That's just 14 years.
mhm.
Mm.
That is just 14 years.
Right.
And so, one of the things that is so critical, and our guest later on will talk a little bit about this, is that knowing your family history, and like the theme of today, no shame in the game, you have got to talk about it. And one of our guests today will talk about the fact that during his vacation, he talked about it openly with his family.
Mm.
And you have to share it, and that gives your family the ammunition, if you will, or the history, to be able to go into the doctor and say, okay, I have a family history.
Mhm,
This is what my dad was diagnosed with, and um, this is why I think I need to get tested sooner. Now, even if you get tested sooner, understand that the levels may be such that they still say we're going to watch it.
mhm.
But if the levels are elevated, still watching it can make a difference. It can make a huge difference.
Yeah.
And, Dr. I'm just wondering when Deb mentioned about the levels,
Mhm.
can you talk a little bit about the levels that people should be concerned with when they should not be concerned with? And, because
Yeah.
I know you hear like five,
Yeah.
4.
Yeah. Usually four for the PSA is kind of the cutoff uh, for normal, but four actually can be considered high for someone who's young. If you're 40 years old and your PSA is four, that's abnormal versus if you're 70 years old and your PSA is 4. Some of it has to do with the size of the prostate, because as you get older, your prostate grows. You got more PSA that's going to be found in your bloodstream. Um, let me talk about what I go through with guys. So I have a conversation with all my men when they're over 50, over 45, if they're higher risk. And African American men, you are considered higher risk, because when we have prostate cancer, it tends to be more aggressive and it tends to be further along. Um,
When you say further along, what do you mean? Like what number would be further along?
well, I mean, it's like, okay, so let's say you come in and at 50, we check your PSA and it's elevated. Let's say it's 4. Well, the average may be, I'm not sure I'm not spit some numbers out, but our average number tends to be higher than
Okay.
than our white counterparts. So and then when we have prostate cancer, it tends to be, again, that more aggressive form
Aggressive, yes.
that spreads. And we're trying to figure out why that is. Is it something we're eating? Is it genetics? Is it lifestyle? What is it that causes that? But anyway, so I tell guys that prostate cancer is the most common cancer in men. Most guys are aware of that. But I tell them that the U.S. Preventive Services Task Force actually had a big issue with prostate cancer screening. So
Mm.
initially they were saying that we should screen all guys beginning at age 50. Actually, they said came out with 55 to age 70. But initially they were saying if you're above 50, screen guys for prostate cancer, and we started doing that back in the early 2000s, and we started finding that we're diagnosing a lot more guys with prostate cancer. It's not surprising because we're screening more guys. So um, the problem was that the number of deaths every year was not going down, even though we're diagnosing more prostate cancer and we're taking more prostates out, called prostatectomy. So it kind of implied then that we were over treating prostate cancer, because most of the cancers we were taking out were these slow growing ones that probably would not have killed the guy.
Oh,
So, and in
wow.
doing so, you're causing problems, causing erectile dysfunction, bladder incontinence, bowel incontinence. You have to wear diapers. There's a big study that was done looking at this, at whether we were over treating prostate cancer. So, the PLCO trial looked at 75,000 guys over a 10-year period. So half the guys, 30,000 some of the guys, were put into the study group. So every year, beginning at age 50, they had a rectal exam and they had a PSA blood test. Then in the other group, the control group, they took 30,000 some guys, equally matched, put them in the control group. They did not get screened. They only got checked if they had an issue. So what happened over this 10-year period is they followed these two groups. The guys who got screened every year, the study group, they were more likely to have an elevated PSA detected. Not surprising, because they were checking them every year. They're more likely than a control group to get a biopsy done because of the elevated PSA. Some of the guys got biopsy related infections, but they were treatable, but they were more likely than a control group to get a biopsy related infection. They were more likely to be diagnosed with prostate cancer than a control group. And
Mm.
then because of that, they were more likely than a control group to get a prostatectomy, have their prostate removed. This is where it gets interesting. They also, because of having a prostatectomy, they were more likely than the control group to develop erectile dysfunction, bladder incontinence, and bowel incontinence. The problem, though, is that over the 10-year period that involved these two groups, the guys in the study group did not live any longer than the guys in the control group.
So why
So,
is that?
yeah, right.
Yeah,
So
so I mean, this one group was really being monitored.
right, right, and
And
and right, and so actually, with even worse than that, the task force said, look, when they looked at the data, they said, look, I mean, there were the guys that were in the study group had clear harms of being in that study group, because that group actually had, again, they had erectile dysfunction, bladder incontinence, bowel incontinence, um, biopsy related infections were higher, and the stress of being diagnosed with cancer. All these were clear harms of being in that screening group, but there's no clear benefit because they didn't live any longer. So they said they completely changed the recommendation. In fact, they ended the trial early. They said, look, have a discussion with guys, discuss the risks versus the benefits. If they want to be screened and they have no signs of prostate cancer, then go ahead and screen them. If they don't have signs of prostate cancer and they don't want to be screened for that reason, then don't screen them. So they completely reversed their recommendation, and that's kind of where things are now. Was that So a lot of people at that point stop screening. And so so now as the studies go on, we're starting to find that there may be an uptick now in the number of cases of prostate cancer because um, um, well, these are the mortality from prostate cancer because we're not screen because a lot of guys are opting not to screen. So
And the reason why, now that's key. Why
hmm
are sometimes they're opting not to screen? I mean, because we can get this blood test.
hmm
And so, but there's other types of tests
right,
that
right.
people don't really care for because I hear some men say they feel violated.
Well, see, yeah,
I
exactly
mean,
right.
like I had just
Yeah,
had this conversation this week
yes, and
in the
that's
household.
right, and that's something that may be changing too because we're getting to the point now where, when you ask a guy, well, do you want me to screen you for prostate cancer? First thing I think of is the finger, the digital rectal exam. Okay, and it's that's all right, I don't want it.
But what are they looking for when they do that? I think that's key for
Right.
people to know.
What you're looking for a mass on the prostate. So you feel a nodule. It'll feel like a hard area on the prostate, which suggests you have cancer. But there is there's almost no one who's diagnosed with prostate cancer who has well, I put it this way. I haven't seen anybody and I haven't heard of anyone who's ever had an abnormal rectal
She
exam
got one.
who had cancer but had a normal blood test. So I think we're going to get to the point, and they're almost here right now, where they're going to say stop doing just routine rectal exams because it is more of a harm than a benefit at this point because it's more of an obstacle. You got to explain to guys why you're getting a rectal exam when often in a lot of cases you're already drawing blood. It's easy to add the PSA onto the blood draw. They'd rather get the blood draw than get the rectal exam. And in almost all those cases, you're going to the blood test will pick up the PSA, will pick up the prostate cancer.
So basically, the rectal exam, you're saying that is if you get the blood test, you don't need to get that, or sometimes you still do.
No,
Because I
yeah,
mean, I'm
so
trying to figure this out a little bit
yeah,
because I think that's the struggle that our men are having, and I want to make sure that our listeners really hear from you your thoughts on
right.
this.
Usually, if you have an elevated PSA, you will get a rectal exam. If not from your primary, then from the urologist. They're going to do that. And things are changing too in the sense that we know that most of these cancers, the vast majority, are slow growing. I have guys with prostate cancer for 20 years, or their fathers had prostate cancer for 20 years, and it doesn't kill them. They die of a heart attack, they die of a
Do they
car
have to
accident.
take anything though? Do they take
No, no, we,
medication?
we just watch it because they're very slow growing cancers. The majority are. The problem is that there are a subset that are very aggressive, like probably what Joe Biden has. They're very aggressive and they spread and they kill you. We can't tell by looking at them which ones are going to be aggressive and which ones are going to sit there. So where things have changed, I said, is one we discussed with guys about the risk versus benefits. But the other thing that happened is that if someone has an elevated PSA now, we're more likely to say, let's get another level in 3 months. Let's get another level in a year, see what it looks like. If the level's still high, but it isn't going up, we're probably going to say, okay, let's continue to watch it. If it starts changing, then that might indicate that that's becoming aggressive and we should, do something about it. If you do get another level and it has changed, then again, then it's probably aggressive. Let's be aggressive and take your prostate out. Things that are changing is that again, as we find more information about how people respond to the guidelines, that's making changes. The the way we treat it is actually improving now. So we got better treatments for prostate cancer. Um, what used to be that you would get if you had suspected cancer, they would do a biopsy. Now we're kind of looking at doing MRIs of the prostate, this, to assess the cancer burden, how much cancer's in there. So
When you do the MRI, what are you looking for?
they're looking for tumor actually on the actual.
Okay, so they'll
Yeah,
see a tumor when they do the
yeah,
MRI. I'm just breaking it down for our
right,
community
right,
today.
yeah. And the thing I don't know the answer to this is okay if you get an MRI because it's right now the standard way we diagnose cancer is Gleason score and grade. So Gleason score, they take a sample from 6 areas of the prostate by doing a biopsy. Now, the only way to really biopsy the prostate is that you have to do a rectal. You have to go to the rectum. So they have to. It's a very uncomfortable test, procedure where they go in with this gun, they have a gun through your rectum, and they shoot the prostate. Take samples of I think it's 8. There's 8 cores. They send them out to the lab, and they're looking at how many of those areas actually have cancer, and then how aggressive they are. So they come up with a Gleason score. Um, uh, so it score ends up being 6 through 10, and I think Joe Biden's was like 9. So that's one of the the
So 10 is the highest.
10 is the highest, right?
So he was
Right.
right there almost.
Yeah, yeah. So um, and then so that's how we kind of grade it. But if you get, and I'm not sure what happens if you get the MRI, how do you going to determine the Gleason score? It's interesting. So, um,
Well, we're going to have someone else that's going to be later this morning. We're going to have someone else
and that'd be a
that can
question I would
talk
like to
about.
ask him.
Yeah,
Yeah,
so that would
Dr.
be the
Malari.
question we'll hold for him. Okay, Dale, we'll
Yeah,
make sure we hold
yes,
that for him
yes,
as well. But that's really interesting because one thing that I noticed that they talked about with Joe Biden as well is that it is spread.
yeah.
It did spread,
And
right?
it tends to spread to bone. That's so any cancer usually spreads to the lymph nodes first because the lymph nodes, that's where your immune system is. It basically is filtering all your blood looking for things that shouldn't be there, infections, foreign bodies, that kind of stuff. And so when it finds something, your immune system gets activated. You make T cells, you make these antibodies to help fight the infection. So cancers are again a foreign body, basically. Even though they're you, they are not you, and they have gone rogue, and now they're destroying you. So usually it'll spread from that organ to the lymph nodes that are near that organ, because that's where the blood supply goes. And so oftentimes when someone has suspected cancer, they'll get what they call sentinel nodes. So they'll get the lymph nodes that are adjacent to that cancer, whether it's breast cancer or prostate cancer or any other cancer. You're going to check the lymph nodes because that's the first place usually where it's going to spread. Because once it gets into the lymph nodes, now it's in your circulation.
Goes
So
on. Okay.
they stage cancers by you got grade to the grade of a cancer is how aggressive it is, and the stage of a cancer is where it is. So if that cancer is still in that area, it's localized to that area where you first got it, it's a stage 1. So if you have prostate cancer, it's still in the prostate. Okay. Stage 2 would be that it now has gone to the surface of the prostate. It's still just the prostate, but now it's gone to the surface of the prostate. Stage 3 is that now it's spread outside the prostate to the lymph nodes or to other areas in the pelvis. So it's still in that same general area, but it's gotten outside the organ. In this case, again, the prostate. And stage 4 means it's gone to other places in your body. So it's gone to the bone. And so
And other
that's
organs
how.
possibly too, right?
Right, and that's right. So that's when you start seeing things, cancers that spread to your brain or to your liver. Those are kind of the areas a lot of times where those cancers go.
And I guess the treatment for that would be
The treatment. The treatment has gotten better too. So if you got stage 1 or 2, your 5 year, because they look at, they kind of describe survival rate as 5 years. So your 5 year survival rate is kind of an indication for how well you're treating the cancer. So the 5 year survival rate for stage 1 and stage 2, I think it's 100% for prostate cancer. So
okay.
if you have prostate cancer and you catch it early, your chance of being alive in 5 years is almost 100%. So that's really good. If it's stage 3, I think it's like your 5 year survival rate is like 80%, and then stage 4, it's like 37%. So it drops a lot. Um, but they're able to treat it better now because we know that because it's from the prostate and because it's a male organ. A lot of these prostate cancers they're sensitive to testosterone, the male hormone. So what they'll do is, in addition to again chemotherapy and radiation therapy and surgery, they might do hormonal therapy, which basically means trying to get rid of all your testosterone. So uh,
Yeah, because I've been reading about that as well.
yeah, so
About yeah.
you can either do and I don't think they do this as much, but you can take the testicles out sometime to just completely just because that's where the testosterone is made. You
Dr.
take the
Izzard,
testicles out. Yes.
I want to ask a question.
Yeah.
So I have a cousin, 2 brothers,
Hmm.
mind you. One we will funeralize on the 20th of this month.
Oh man.
One that has been treated for the last 2-3 years for prostate cancer.
Mm.
Again, one did not make it. It the brother that did not make it, it has traveled and actually made it to his brain.
Yeah.
Uh, so, and the difference there, as you spoke to, was when they caught it,
Right.
if you will.
Right.
So, one, he takes a pill and this, that, and the other. He goes in and they monitor it. So, how much does lifestyle play into this diagnosis, if you will, or the progression of the cancer itself?
Yeah.
Does that ever speak to the progression of the disease, or does it not?
Well, yeah, boy, that's a
Lifestyles.
good question, because
Mm.
that's one of the things that people are trying to find out. Is there something that a lifestyle thing that we could point to that indicates, your risk? So they looked at even things like how frequently you have ejaculations, and how does that relate to your prostate cancer? And there's nothing that's really been, other than the general healthy stuff, that's really been shown to increase that risk for prostate cancer. Family history is definitely one, but I would say the main thing is that if you're of that age, you really should be getting checked every year, because like you said, if you catch it early, if you can catch it before it metastasizes, your chance of surviving is pretty good. But you gotta be getting in, and so a lot of us guys. And
When you say of that
talk about
age,
this.
though, doctor, is it what
Yeah,
age
I
are
was
you
just
Well,
saying?
wondering
see,
about
that's
that.
so. If we'll say this, so the current guidelines. So I'm talking about the guidelines because we're going to find some people are outside the guidelines. Again, Joe Biden was one of the people that was outside the guidelines. But guidelines say if you're 50, between 50 and 60, between 50 and 70, you should be getting PSAs once a year.
So
If you're high risk, meaning that you have a first degree relative like a brother, father, with prostate cancer, you should be starting to get screened at 45.
Mm.
Okay.
So now again, just so we're clear,
hmm
uh, is this something that you're more apt to see in African Americans? Is it race driven? Do you see more numbers in the African American community versus Caucasian?
Yeah, we have a higher incidence, and we tend to be more aggressive when we do get it.
you know, Dr. Izzard, I was just wondering too, and I'm gonna jump in, Debo, a little
Go
bit
right ahead, Ms.
because
Karen.
I when I was reading about African American men, they were saying typically maybe they should start at around the age of 40.
Yeah.
That's kind of early, isn't it, or what? I
Yeah,
mean,
see,
it's like it's
right.
getting earlier and earlier for us.
Right.
So, Deb, I see you shaking your head. What's your thoughts on that?
Yeah, so again, I have not gone to medical school. I am not a clinician.
Right.
However, with the research, and Dr. Izzer, please, and the doctor comes on later, can also help with this information. I think that there's several things we need to take into consideration, and Debo touched on it with lifestyle. And the gentleman that we have here today can also help support some of this discussion. Uh, it's what we eat, how active we are,
Mhm.
our sedentary lifestyle of just um, of sitting around and not being active, um, that impacts our overall lifestyle and our risk level on so many different levels.
Mhm.
And also, I want to put it our stress level.
Right.
Yeah.
Our stress level is really
The
you
reason
know-
why I was asking about that age 40 or 45, Dr. Izzard, is because the possibility of African American getting prostate cancer is so much higher. We need to be a little bit more proactive
Right.
than the average. That's
Right.
what I'm thinking as we kind of think about this.
Keep in mind also that getting prostate cancer and surviving prostate cancer are different things. So, your general health is going to make a huge difference, even if you get it, about whether you survive it. Because if your immune system is compromised, if you're overweight, if you got other comorbid things, your chance of dying from prostate cancer is going to be higher than if you're healthy and you get prostate cancer.
We're going to continue with this conversation. I have Dr. Kevin Izzard, who is a family practice physician with us, Deb Neville from the Medical College of Wisconsin in the cancer prevention. And I'm Karen Dotson, and we're going to talk more about prostate cancer. And you all, we have a whole bunch of men in the studio with us today. We have to look for more chairs. I mean, it's a great feeling to see these brothers here to really encourage and talk to the community about this important issue related to men's health and prostate cancer, and how they have been able to handle things and what their recommendations will be for this journey that people are taking through this process. And so we're going to be back on the other side. If you want to call in, please feel free to call in. You can call in at 414-444-5253 or 414-444-5250. We'll see you back on the other side.
It's like a diamond ring, it's a precious thing. And we never want to lose.
I want to welcome everybody back to At the Table this morning. This is Karen Dotson. I have along with me Dr. Kevin Izzard and Deb Nevels. And we've been talking about men's health. And we have a bunch of men in the studio today, Deb.
Look,
I love it. I love it. I love it. And Deb is going to introduce
You
them
got
in
a
a
whole
second.
bunch of men.
A whole bunch of men.
A whole
Debo said a
bunch of men.
whole
Don't
bunch.
make
Yeah.
no bunch of
Because
men, it's a
actually
whole
we
bunch.
have a total of, 5 additional men besides Dr. Kevin Izzard.
Yeah, I thought we was on the porch with choir.
No, yeah, but
I don't ask them to sing.
yeah,
Don't
but
go there.
but and Dr. Izzard might be able because he's a praise leader.
Hey,
So
I'll back you, Jermaine. I was back up singing.
yeah, but
We got a tambourine.
Gosh.
Woo, woo.
And he started dancing.
oh my
Yeah.
goodness.
And that's it. That's
Yeah.
all.
He also he's give him the tambourine
Oh, Lord.
and what else?
Okay, so we're gonna do
And the drum.
tamarines and
And the
drums.
drums.
Okay.
Oh, goodness.
But you all we've been talking about something that's been very serious and very important in our community, and we've been talking about prostate cancer. And during break, Dr. Izzard and I, we were just talking about this age thing as far as when people should be. And Dr. Izzard, I want you to respond to that.
So you're gonna see you might hear different conflicting recommendations because guidelines are kind of we talking about the U.S. Preventive Services Task Force. They're kind of like the premier group. They're a national organization. They basically take people from different specialties and they come up, they look at the data and they make a recommendation. But there are other organizations like the American Urological Society. So these are urologists. They make recommendations. The American Cancer Society has recommendations. And so you might find different recommendations. So most people kind of go by my mind is one blank.
That's PTA.
The
United States.
the United States.
Yeah, so I mean,
But,
Dr.
you know,
Doctor, we know what we've been working our doctor too hard.
Yeah.
I'm gonna tell you, our doctor. Every time I've been talking to him lately, they working him too hard. We're gonna have to pray
Yeah.
for our doctor because we need you, doc. But go
Yeah.
ahead.
But most people go by the United States Preventive Services Task Force.
Yes.
recommendation.
Okay. And that's where you were
Yeah.
talking about that
Right.
age 50, right?
Right. But like the American Urological Society, I think might say 40 for screening, and the American Cancer Society, I think, is 50 also. I'm not sure, but yeah. So you'll get different recommendations. And think about this: if you're a urologist and you're seeing prostate cancer, you're seeing all the aggressive ones. You're seeing the ones that that the primary doctor is looked at, tested, and sent them on to see somebody else. So they're seeing the more aggressive forms, and so they're more likely then to be aggressive with the cancer versus like for me, I have a lot of guys who have prostate cancer and they haven't had their prostate out and they're doing fine. So I like that
perspective. I like that perspective.
So I'm less likely to be aggressive, although I will send them on at some point if they have prostate cancer to talk to a urologist. But then what happens is we have a conversation afterwards. So the guy comes back and they say, okay, the urologist recommended this. 99% of the time I'm gonna say, well, let's go with whatever he recommends. But sometimes I might disagree with what the urologist says, and so we can have a conversation. And that's what you need to do. You need to have a conversation with your provider about what's best for you. Because I said, with these guidelines, they're looking at large numbers of people. They're not looking specifically at what your case is. And so even with treatment, there's you got radiation, you got surgery, you got chemotherapy, you got hormonal therapy. So and they all have their pluses and they all have their minuses. And so you have to have that conversation about what's best for you.
We have a question in the studio.
Yes, ma'am. Doc, now I
Mhm.
know last year I had my surgery for prostate cancer.
Mm-hmm.
And how I found out I had prostate cancer, I was having surgery on my ankle.
Mm.
And I had to do lab work before the surgery.
Okay.
So they did all of my lab work and found out that my PSA was at 13.8.
Uh-huh. Wow. Okay.
So they was like, something is going on. They put me in and found out that I had a tumor.
Right.
But one of the doctors, when they asked me what I wanted to do, they was like, "Do you want to do surgery or do treatment?" And he
Right.
walked out of the room.
Did he really?
One of the nurses' aides came
Mm.
in the room and said, "I'm gonna be honest with you.
Uh-huh.
Don't do the treatment.
Uh-huh.
Go ahead, have the surgery, get it removed.
Mm-hmm.
Because if you do the treatment, they just guessing and shooting at it, and it ain't guaranteed that they can hit it and
Right.
cure it."
Right.
And I had my surgery, and I think it was one of the best things that I've ever done because after I went and had my checkup a few months ago, just to check my numbers, everything came back normal, and they was like, that there's no sign of cancer or anything like that. So I asked the doctor, I was like, "Is there any foods that I'm supposed to stay away from?" He was like, "Well, no, I mean, you could pretty much eat anything." Well, I don't believe that,
Mm-hmm.
but it was just the
Right,
point
right.
of, I'm like, well, how did I get this
Right.
out of all of my brothers? Now I know my uncle had it on my dad's side. He passed away. His son had it. He passed away. My other uncle had it. So I know it's
It's
something.
in the
It's
family.
in the family.
Yes,
Mhm.
yes.
But it skipped over all my other brothers
And you got it.
and hit me.
Yeah. But boy, you were blessed that you were able
Found
to
it.
found it. Yeah.
Man,
Because
Thank
you
God
didn't-
for the broken
Yeah.
ankle, huh?
listen, and I was
God has a way, right?
and I was dealing with the ankle pain for 17 years.
Yeah.
Wow.
And my guess is you never had a PSA drawn before this.
Never. And he kept telling me, he was like, you probably should get your PSA, check it all your numbers. And I always had this in my head of
Mhm.
how, they do the test.
Mm-hmm.
Mhm.
So I'm like,
Yep, we were
okay.
just talking about that
Yeah,
test and how
no,
men
doc.
are like, no, yeah.
So when after they did the blood
The
test,
violation. That's what
Yeah,
I gotta
so
say.
I went and got violated, and
Got violated. Why you gotta word it like that,
I'm
man?
just saying, man, that's what happened. I went
went
and
and
got
got
violated
violated.
and looked at her, told her to call me in the morning. But
Well, that's kind of interesting. My husband felt the same way when he.
Yeah.
yeah, I'm like, hold on.
I mean, they were like, he said, "Oh," I said, "We're gonna have to."
But I'm so glad I did though, because
Yeah.
again, I had no clue, and when they told me, it was like a shocker. I'm like, how?
Mhm.
Right. Right.
And but I'm glad that my faith was able to keep me
Mhm.
Grounded, yeah.
and just to go through the process. But I was worried about, is it a possibility while I'm
Reoccur.
waiting for the surgery that it would spread?
Yeah.
Right. Oh, I see what you're saying. Because
the
it's in
thing
there.
you got to consider is this. So, and deciding whether you want to have surgery or not, and surgery is probably the ultimate test that's going to get rid of it. They're doing a lot better now with these surgeries where they're nerve sparing. So
Yeah.
because the big issue is going to be erectile dysfunction, and so a lot of guys will say, oh, if it means I'm going to lose my ability to have erection, I don't want to. I'd rather have the radiation. I'd rather have
Well, now, doctor, what they do is they use the robot, and I got 6 incisions
Mm-hmm.
across my stomach, so they went in and
Yeah.
went around all of the nerves.
Yeah.
And
Yeah.
they was able to spare the nerves, so that's the procedure that they.
Right.
But the
does.
thing is, if it didn't work before the surgery, don't worry about it after the surgery.
All right, Debo says something. He doesn't have a mic right now, but
I'm gonna turn his mic off.
yeah, but he doesn't. Oh, he
It
doesn't
didn't
have
work.
a mic. Oh,
If it didn't
okay.
work before the
Okay,
surgery, why
okay,
worry about
but-
it after
Well,
the surgery?
yeah,
Okay,
and
but-
that's something to keep in mind. So
Wow.
if that's not an issue for you, then maybe then maybe go ahead and get it out. Other thing too is that there's a good number of guys who are going to get urinary incontinence, so they might have problems with the urine leaking, and they have to wear a diaper. So that's another thing to
A
consider.
lot of
That
challenges.
was one of my main concerns too, because I went through that
Right.
time period for
Mhm.
a few. So I'm like, okay, do I gotta live like
You don't
this
have a
forever?
mic.
Right.
You don't have a mic, so people don't know what you say. But what I would like for us to do is Deb have a couple people that she wants to introduce right now. And I want to thank you for bringing them to the studio. And you're going to tell us their story, right?
No, they're going to tell their own story.
All right, you're gonna introduce them?
I'm going to introduce them, and I will tell you this is a blessing. Part of the reason why I love the job that I do is that I get to work with some wonderful individuals who are community members that are working to make a difference. And as we were talking, and I'm still going to work on Jermaine because he should be in this group. We Medical College of Wisconsin has a project that we worked on. When we talk about research, it was first the moving forward research that looked at lifestyle changes and the impact once people are diagnosed and out of treatment for prostate cancer, that was run by Dr. Melinda Stolley. Um, After the men finished the program, it was 16 weeks. Guys, yeah, 16-week program. Um, it was like, now what? Because they enjoyed. It was the getting together and talking, and they still went to the exercise classes after they even graduated. We needed something else, and so we created this program called Health Griots. And so the Health Griots, which we have several of them in the room today, they are trained to tell their story. They were trained by Ex Fabula to tell their story of their journey through prostate cancer diagnosis and treatment, and now survivorship. And the main thing is this whole piece that we have with No Shame in Your Game. The focus is that you've had this the test, the violation. They've gone through treatment, and now they're on the other side. And being able to go to, we have a couple of activities that are going on in the community that we want to tell you about. And I want to introduce one of our griots, Mr. Vincent Butler. He is a first-year health griot. He's also with St. Mark AME Church. And also we have Mr. Brian Mitchell. He's with the Sons of Allen, also with St. Mark AME Church. And they're going to talk, Mr. Butler, I'm going to ask you, you have a perspective specifically focused a little bit on the importance of healthy eating. And with your diagnosis, how has that changed your life, and how you have gone about changing your diet?
Okay. Yeah, I'll give a little bit about my
Please.
story. Is I was diagnosed in 2007. I was 51 years old at the time. So it was a scary time. It was a routine. Just, I get my annual physical. I go to my physical, and my PSA is elevated. So I go through the biopsy, and I'm told that, you have prostate cancer. And I didn't feel a thing. In those days, I was really athletic. Because one thing, to celebrate my 50th birthday, I did what I called a triple header. I played softball at Cy John Field at 9 o'clock. After playing softball, we went to play an hour and a half of basketball. Then I played 18 holes of golf that day, just to show that, I still got it.
He was very active, very active,
yes. I was going
yes.
to do it the next year, but I had prostate cancer. I'm talking too loud. But I didn't feel a thing. That's the scary part about it. I felt as good as I did the year before. And I think that's the lesson for, for the folks that are out there, the young men who I think anybody's under 60 now, is what you don't know can't hurt you. So my story is get checked out. Then you have options. So the option I opted for, because of my age, I was 51 at the time, was for surgery. So I had my prostate removed. And there are issues with that. There's things, but there was choices. And I remember the thing that got me over was I had the bone scan right after I got diagnosed. You had the bone scan, and the nurse called me up and said, "There's nothing there. You're okay. It's just isolated to the one spot." So I opted to do the surgery, and I don't regret it. It's been it's 2025 now. I'm still here.
Wow,
so,
that's
I think the
wonderful.
lesson I have is early detection. Then you have your options. So if you wait later, then it's going to be problematic. But as far as healthy eating goes, I just think, what you do is, I know the one thing I'm trying to do now better. I still got challenges for it because I love barbecue. I love my barbecue. I love my pork. I love all that stuff. But I think the thing to do is that what I would like people to do is cook for themselves. If you eat at home,
You know what you're
you know
eating,
what you're
right?
eating. So I think that's important that you do that. And then what you have to do is, when you shop, there's a difference. I work at Outpost Natural Foods in Milwaukee, and one of the things I always talk about is spaghetti sauce. and you got spaghetti sauce that can run like $10, $12, and others like 150 or whatever.
Mm-hmm.
And what you got to worry about is the sugar involved in it, because the cheaper items, there's more sugar involved in that. So you got to be careful. So you have to make decisions as far as your grocery shopping go. You buy your fresh fruits and vegetables. You don't eat out as much as you eat out less, and those are the things that you do. You just portion control, obviously, which is a problem for me. But I think cooking for yourself, this is something that, in addition, that you cook yourself, you're going to be better off than if you're eating at a fast food restaurant. It takes you as much time to cook a hamburger with whatever as going to one of the fast food restaurants. So that's
Yeah.
that's 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 my thing. And I'm thinking what I want to do is for young men to get tested, to get treated early. I think earlier the better, because then you have options as opposed to being advanced.
Hmm.
So that's my story.
Okay, thank you.
Thank you so much.
So Deb, I know we have a caller on the line, but caller, can you hold on a minute, because I want to make sure we talk to our other guests first, because our time is getting kind of
Yeah,
late
just
here.
give me
So
a
can
second.
you introduce our next guest?
Yeah, Mr. Butler. I'm sorry. Yeah, no,
Right.
Mr. Mitchell.
Mr. Mitchell.
So a lot of believe you want to start it out getting on the walk, but you have an event coming up and want to talk a little bit about that.
Yeah, Mr. Butler, we're going to go on break, but if
Oh,
you can you mention it before we go on break?
Sure thing.
Okay, real quick, and then we'll come back to you.
The Sons of Allen is the men's ministry of the AME Church. So I was at St. Mark, as well as have a event that have cancer screening as well as kidney screening on June 28th at St. Mark.
June 28th, and where is this St. Mark? Okay, I know where it is, but I
St.
don't know.
Mark,
Okay, what's the date on that?
June 28th.
Number two. We're going to take a quick break. This is Karen Dotson. We're at the table today with Dr. Kevin Isner and Deb Nevels. Dr. Isner, I know this is about your time of day that you cut on out to see your patients. Yeah. But any words of wisdom before we cut out with you?
Yeah. Women are far better at getting this treated. I mean, have years of most guys I see either their job's making them get it, or the wife's making them get it, somebody, or they got something extra. Yeah. Or they want to buy a one day fun on
Your wife making them get it? I know I do. That's right.
Repeat
That's
that
what we're
one right
supposed to
there.
do,
Wife
right?
make them get it.
That's right. We put making sure our men are okay.
Yeah, but I think we're afraid of people. I mean,
Yeah. Okay.
but yeah, we go out, don't be afraid. We're intended to, and this is for everybody.
Dr. Is it? Dr. Is it? There's still one factor that we spoke to the wife making them get it. This, that, and the other. Sometimes it's just that total lack of help.
And we can talk about that too. We'll talk about that. I agree.
Not getting the diagnosis, not getting the form, not seeing a physician as often as you should. If you don't have coverage.
Yeah. Listen, this is good conversation. However, we have to take a quick break.
We got to pay some
And
bills.
we got to take a break. You all are looking at me, and then you all getting in the conversation.
Yeah.
But
I told you
listen,
to take a break and then I'll start talking. Yeah, you go ahead and point me out.
Yeah.
Thanks a lot, Mr.
Hold on the topic.
yeah, but we're
It's
gonna talk.
real. It was pointed at that particular point in time. And the break will be there. But we're talking about folks' lives. So it's important. We'll get that break. Let's roll.
All right. We'll see you back on the other side. We're at the table this morning.
It's like baby, there's something to say. Every time we hear you.
I want to welcome everybody back. This is Karen Dotson. We're here today with Deb Nevels, and we have a group of men in the studio today to talk about mental health as well. And so I know we have a caller on the line, but we're going to still put you on hold a little longer because we want to make sure we get in. We're really kind of squinch with our time, and we want to make sure we get in the conversation with these men because I think this is important for the community to hear about. And so, Deb, I'm going to give it back over to you because I know you have some new folks you want to introduce to us.
We have new folks, but I also want to go back. Part of our intent and part of what the work that we do, Karen, you and I,
Mhm.
is that it's not only bringing the information to the community, but then also elevating opportunities for the community to get engaged and part of the partners that we collaborate with. And we are blessed to have two of our partners at the table who happen to plan events on the same date. Y'all, really, is this what we're doing? But that's okay. That's okay. Because it's all about men's health. What is really critical is it's not only about men's health, but it's also really important that they get access to care. So, Mr. Mitchell, I'm going to go back to you with regards to the event that you're having. And I want to go a little bit into the why. Why are you doing this particular event? And give us information again on the event itself.
Sure. Well, June is National Men's Health Month as well as National Men's Mental Health Month. So for the month of June, we're trying to find an opportunity, and we've had a great partnership with the Medical College of Wisconsin's Cancer Outreach Program over the last 3 years. They came to us. We have a couple of people that we put forward to the GRIO program. You heard Vince Butler earlier. And so, in support of that initiative, we wanted to have an event that gave the opportunity for men to tell their story to other men. So, a lot of times we don't talk about men, we don't talk about these things. All right. And so, personally, I'm 54 years old. I have not had prostate cancer. My father survived prostate cancer, and my mother's brother survived prostate cancer. So it's in my family, and I've been doing and getting tested since I was 40 years old because it did show up in my family. So
It's a doctor.
I've got an awareness, and I think it's important that the gentlemen who have survived it reach back, tell their story to help us coming along the way to not be so apprehensive about these things. So yes, we can kind of talk and joke around about the violation and getting that digital rectal exam, the DRE, but there now are other tests and things, and you may not have to go that route until that's not the first option, right? And so we want to kind of dispel some of those things and show folks how they can come through on the other side and start off younger so that we have a better instance of survival.
Awesome.
Deb. I know we also have Dr. Kalari.
Dr.
On the,
Kalari,
yeah,
yes.
he's on too. So I'm wondering if we can kind of like get him in and have that conversation, and then we can start talking more with the other men around the table today.
Definitely,
Okay.
definitely. And Dr. Kalari, thank you so much for joining with us today. Dr. Kalari, for those who do not know him, he is a medical oncologist and a hematologist at Frederick and the Medical College of Wisconsin here in Milwaukee. He has a particular focus on personalized care and advancing clinical research for diverse patient populations. Dr. Kalari, thank you so much for joining us.
Thank you so much for having me.
Oh, definitely a pleasure. And we had a question earlier that now I cannot remember what it was when Dr. Izzet was here. But as you know, Dr. Kalari, you have been extremely instrumental in several of the gentlemen that are around the table with me today, with the Health Griots and with the Men Moving Forward project. Can you talk a little bit about your role in working with these gentlemen and with these projects?
That's a great question again. Thank you so much for having me. I was really fascinated at the program that Dr. Stoley and her team had created, where a lot of times when you see folks in the clinic, right? I mean, I'm a medical oncologist, so what we do is we see patients or men with stage 4 prostate cancer, and we recommend treatments, but we don't really think about what the side effects of treatment. I mean, we think about it, but we don't spend much time with patients thinking about the side effects of treatment and how or what we can do to help patients out. So when Dr. Stolly had created this exercise and nutrition program for men for prostate cancer survivors, it really sort of took me, sort of said, okay, this is what we really need to do for everybody with prostate cancer survivors who finish treatment and prostate cancer patients who continue to receive treatment. So from my perspective, I was sort of like fascinated and wanted to be involved because I sort of thought I could learn myself about all of these exercise programs and all of these nutrition programs, and sort of like take that information down to people that I treat with prostate cancer. I was at a meeting this weekend actually in Chicago, and there was a study that was done where they took men with colon cancer, and half of them got exercise, a regimented exercise program like what Dr. Stolly had done with the Men Moving Forward program. And the other half did not get an exercise program. They basically did what they were doing. And the results showed that men who actually exercise live 10 months longer than men that don't exercise. And this is better than any drug out there, right? If you think about it, the drugs that we have make people live for 4 to 6 months. Exercise program actually made men live for 10 months longer than men who didn't exercise. So this just reinforces the benefit of exercise and what Dr. Stolly has done and how much I've learned from this program.
Dr. Kalari, this is Karen Dotson, and I just have a quick question for you related to the exercise. How much time should a person exercise a day that's considered that would be enough to help with this situation?
So the guidelines basically indicate that men should exercise at least 5 times a week, and it should be moderate exercise. And I think there's this thing where people talk about what moderate exercise is. So if you can sing during your exercise or if you can talk during your exercise, it's not really moderate exercise. It's only if you need to stop to take a breath and talk, that's called what we consider moderate exercise. And the guidelines indicate 300 minutes of exercise. That's basically almost 60 minutes of exercise per day, 5 days a week to be considered moderate exercise that's going to really impact people. I know that's not easy, but at the same time, if you start small, I think a lot of us can get there.
Definitely, definitely. Thank you, Dr. Kalari. We did figure out the question that we had, and it is a question that is a Dr. Kalari question. So earlier we were talking to Dr. Izzard, and we were talking about the Gleason score. And if an MRI is done, how do you determine the Gleason score through an MRI?
So that's a great question. So far, what we've been doing is that when we see something on the MRI that is concerning and suspicious, we actually end up putting needle to the prostate, and that's what tells us that this man has prostate cancer, and the prostate cancer is this Gleason. However, we at the Freighted Medical College of Wisconsin, and especially Dr. La Violette, has created this amazing program where he's using artificial intelligence to actually capture what the Gleason score is without a biopsy, right? And I think this is very great research, in my opinion, because if you can tell a patient that you have low risk or low Gleason prostate cancer without a biopsy, which has side effects, probably do nothing for those patients. They would just keep monitoring them. But because we don't know what Gleason score they have without a biopsy. Right now, we still do a biopsy, but the goal and the hope is that with time, with technology, we will able to tell men that you have a Gleason 8, 9, or 10 prostate cancer, or even a low Gleason prostate cancer, just based on a biopsy. Sorry, based on a MRI rather than a biopsy.
That's one of the reasons I love working at the medical college. It's
Right.
you have a question trying to figure it out, and there is usually a study that is going on about it. Um, the other I want to also bring in, we talked about the fact, and this is one of the reasons um, that having shows like this is so critical, bringing the research to the community. And a way that we also do this is through partnerships and collaborations. And another event, as I said, that we're doing and that we're partnering with is with the Family Development Center at St. Matthew CME. And we have Mr. Shelton Watkins here with us today to tell us a little bit about that project and that program also happening on June 28th. So if you could share with us a little bit about that event and why that event is so important to you.
Well, thank you very much, and thank you for having me on this morning. Uh, St. Matthew CME Church, we sponsor a health fair annually. I am the program director for the Cornelia Family Development Center. It's an outreach ministry of St. Matthew. And for the last several years, we have really been focused on healthcare, especially for men. During our last event we had at our Ninth Street campus, we had over 50 men that participated in the health fair, and we focused mainly on prostate cancer, and also we expanded it to colorectal cancer and overall health concerns for men. This particular event that's coming up on the 28th, Saturday, from 8 to 1 p.m. at our 76th Street location, 7500 North 76th Street. We're again going to tackle men's health, and we're going to have a breakfast to start out, and then we'll have speakers, doctors, and other clinical folks to come in and talk about men's health overall, but we'll focus again on prostate cancer because we'll have the health griots there to tell their story.
Awesome, awesome. And again, this is what's so important. And Dr. Kalari, I want to circle back. This type of community engagement, how does having these type of events and increasing community engagement, how does this really improve our outcomes in things such as clinical research and care, especially when we look at underrepresented populations?
Great question. So there's been a lot of misperception about the role of PSA at screening, right? A lot of times, so 10 years ago, we were basically doing PSA for everyone. Every man above the age of 50 was getting a PSA screen, and we were diagnosing a lot of prostate cancer, but we were diagnosing a lot of patients with indolent prostate cancer, and we would put them through treatment. But we realized that over the years, not all men need treatment for prostate cancer. So what happened was, from every man getting a PSA, the pendulum swinged and the guidelines changed, and they basically said, do PSA screening only for certain men. But a lot of doctors took that information and took it in a completely opposite way and stopped checking PSAs. And men started hearing that, oh, I don't need a PSA, I don't need a rectal exam. And basically, folks stopped doing what we were doing 10 years ago. And what we did see as a result of that is we started seeing a lot more patients with stage 4 prostate cancer compared to early stage prostate cancer. So these community engagement events, I think, in my opinion, bring a lot of help for both patients and providers. If you think about it, right, education about who needs prostate cancer screening, who actually needs to have what symptoms prompt you to get a prostate cancer screening, what the family history, what family history does play a role in prostate cancer. We all know that African American men are more prone to prostate cancer and they have more aggressive prostate cancer. And the only way we can actually help underrepresented populations is actually have them understand, or have us and them understand why they have cancer more frequently than other men. And also, why is that cancer behaving differently? And if you look at the US trials, right, most of the trials that we do or the studies that we do in the US, we find that if you have 100 patients, only 2 to 3 are underrepresented. So, in other words, you're giving a treatment to underrepresented population based on what you see in a white population. And I don't think that's the best thing, because you have to understand that um, you need to know where things are and everything else. Uh, can you just hold on for 1 second? I just need to pause myself for a
Go
second.
right ahead, Dr. Kalari. Yeah.
Okay, yeah, I did have a question for him, but Deb, why don't we just introduce some of the other people that we have here
Yeah.
right now?
Well, I think what part of what Dr. Kalari is saying is so critical. And I think um, one of the things that we are trying to express today, not only with our community partners, but also with our health griots, is that knowing and having this knowledge is critical to being able to catch it early, and and the diagnosis itself does not mean that your life has ended. Our health griots are living proof that exercise, healthy eating after diagnosis um, means that your life, you have a new leash on life. And I think one of the gentlemen that I have with me, or all of the gentlemen that I have, I want to focus on Mr. Hayes. He's also a member of St. Matthew CME, and he's a first year health griot. And also very, very, I'm honored because my dad was, he served in the military. And I'm just curious about how your military service possibly shaped your approach to life, and or your approach to health. And what do you hope others take away from hearing more about your journey?
Well, thank you. Well, my military service came after my athletic service in the military, in high school and college. And when I was coming out of college, you had to go to the military because it was a draft. But going into the military was just one part of my life. Um, the I've always been a disciplined person in regard to exercise, and that because of my uh, career as a football player in Central State University. But my prostate journey started when I was 55 years old. I developed frequent visits throughout the night, going to the restroom, and it was determined that I had enlarged prostate. At age 55, I had my first operation, which was a TERP, and it's a transluminal resection of the prostate. And at age 74, I developed stage 1 prostate cancer, and I had the radical robotic laparoscopic prosthetic surgery. And on my next birthday, I'll be 85 years old. I've been a health griot, or been a part of the Men Moving Forward program for the past year. I'm a member of the Million Men Veterans Organization, which is a volunteer organization where they take samples of your blood and then they use it for research to determine other diseases, kidney disease, heart disease, things of that nature. Um, uh, I,
You are a busy man.
Yeah,
Always
you
thinking
know,
of
it's
things.
very encouraging to hear that, number one, your age, and
Yeah,
number
that.
two, the survival rate. And when you found out about having prostate cancer, and now you're still actively involved, so that really says that it sounds like you were very active and in your life, and that it kind of goes to what Dr. Kalari was saying, as far as the importance of being active and doing your exercise and things of that nature. But Dr. Kalari, I know that you're back now with us, and so I do have a question for you, Dr. Kalari. As far as
Yes.
age, what is your recommendation for African American men to get a test for prostate cancer? Because we hear 50, we see sometimes 40, 45, but I would like to hear from you because you're doing the studies. You're actually seeing people and you know what's going on. So what would be your recommendation for African American men?
So I would say that the minimum age should be 50. And if you have a family history of prostate cancer, if you have somebody in your family with a history of prostate cancer, I would say 5 years younger, 5 to 10 years younger than, or I would say 10 years younger than uh, the family that member that actually had prostate cancer.
You know,
So, for instance,
yeah,
if
go
you
right
had
ahead.
a sorry. So, for instance, if you have like a uncle or somebody that had prostate cancer at 50, you should probably be screened at 40 years of age.
Doctor, and that's what I was just going to say, that it's so important that we talk about this in our families, in our communities, in our churches, because if you don't know in your family if someone has the prostate cancer, then you don't know if you're at risk or not. And so that's really important for us to discuss and talk about. And that's some of the things, Deb, with your program, you all are doing is really encouraging people to be a spokesperson for this.
Right. And I mean, speaking up about it, and that's one thing one of my old bosses would say, it's what kills is silence kills.
Yes.
Secrets kill. And so knowing this, I mean, knowing and like Mr. Hayes said, his diagnosis was at 55. So his sons and can know that at 45, that's when they should be getting tested. But if you don't know that, if you don't know that your father had or brother or uncle or whomever was diagnosed, if you don't know the age of when they were
Mhm.
diagnosed, then you won't know, when you should start getting tested. You don't have that information to take to your doctor.
And that's a key, what you're saying, take to your doctor,
Take to your doctor.
because you
Yes.
need to really, because a lot of times when you go and they give you this questionnaire
Yes.
and they ask these questions, and before I became very knowledgeable about how I need to, what was the purpose of that, and I hear others too, is that they want to know your family history so they can say, because of your family history, these are the things that we recommend for you to get in advance to be more proactive with your health.
Yeah, and some of us we have to understand because, like, use myself. I was adopted. I didn't know my family history, so I found a doctor that listened to me. And when I went in, I was like, okay. He was like, let's do it. Some trait, and so therefore he was like, I need to get baseline on several different things.
Hmm.
So he did baseline for me. So then there were things that we knew we had to watch. So that really helped with, and you have to be able to stay in the so we have to
Yes.
and be willing to listen
Mhm.
and to go that extra step to
We're going to take a break in a minute, but I wanted to, because I know Dr. Kalari, you are limited with time. So I wanted to get last words from you related to the studies that you're doing, the recommendations to the community, and what can we do, to make sure that our men are safe and healthy.
Thank you so much for that. And I really apologize that I cannot stay longer. There's a couple of things I really want people to take away from this meeting. One is uh, exercise and nutrition play a big role. So please consider exercise
You're kind of going in and out.
Can you guys hear me now?
Yes.
Okay. So what I want to basically emphasize is that screening is important. Know your family history. A lot of times people don't know about the family history, but talk about it to your friends, your family, because you're talking to them is actually going to make people aware of prostate cancer and what we can do to prevent it or what we can do to decrease the mortality from it. Healthy exercise and nutrition, irrespective of whether you have prostate cancer or not, it's going to help. It's actually better than the drugs that we have out there. Please.
Like we lost.
Can you guys hear me?
Yeah, you're going in and out, but I know we're going to have to take a quick break. But Dr. Claus, yeah, Deb will definitely have you back. And I want to thank you for the work that you're doing at the Medical College of Wisconsin and the research. It's so valuable. So thank you for joining us today. And we look forward to talking with you again. The community wants to hear more from you. So thank you. Take a quick break. This is Karen Dotson. We have along with us Deb Nevels, and we have a really good group of men here to talk about prostate cancer, the challenges, and also Men's Health Month. We're going to be just getting updates on some of the things and activities that are going on this month that you can also participate in and also get good information and also good food too, right? It's going to be good food at some of these events. So once you just keep listening with us, we'll be back on the other side. I want to welcome everybody back to the table with Karen Johnson, who is also from the Medical College of Wisconsin. She's really involved with a lot of career outreach engagement with cancer. Yeah, you did an awesome job today by bringing in so many really wonderful men to talk about Men's Health Month.
Yes, we are so excited and we're so blessed. I mean, it's just being able to work with these gentlemen is it's a blessing and it's so much fun, and just seeing the impact it has on the community is really really important. One of the things that's really critical in working with our health griots, who are men who have completed a program, a research study called Men Moving Forward, that is run by Dr. Melinda Stolley at the medical college. They've graduated and now they are blessing us by being health griots, which are they tell their story about their journey through prostate cancer diagnosis and now survivorship. The key thing is to understand that getting a cancer diagnosis is not a death sentence. It is what they are doing is living proof of life after diagnosis.
Yes. And and that's really key, living proof. And I know that, our time is getting very sensitive here, and we still have a couple more men that we haven't even introduced yet. And so I want to make sure that you get the opportunity to introduce them.
Definitely. I want to get to one of the gentlemen who I am in contact with him weekly now, Mr. Bethay. Mr. Bethay is a health griot. He is a first year health griot. And he does a lot in the community. It's difficult for us to tell him no, because he's so active in the community. And Mr. Bethay, can you tell us a little bit about your story and your why of why you're doing this work?
Well, thank you for having me here, giving me the opportunity to speak to my extended family in the community. For me, the journey came because I was having frequent urinations at night, 3 to 4 times. And I did have a PSA. What I did know is how your family history really played into this. I come from a family that all of my immediate family, my 2 brothers, mom and dad, all died from cancer. So when I was having these problems and had to go check to see about my cancer, I didn't have any real information on what to do because my dad never spoke about it because he didn't have prostate cancer. He had abdominal cancer, but there was no discussion about health when I was coming up. My 2 brothers passed with cancer. One was brain cancer. So having cancer in the family and getting a diagnosis, I would just say that I wish I would have had more of a spiritual connection with someone, because going through it and then knowing that you have a family that's have had cancer is really something that's kind of holes in your brain. I went to bed a couple nights, of course, thinking I wasn't going to wake up once I got the diagnosis. The room felt like it had no air in it, all of those things. But I came through it because of my faith. And I really did do the things that they asked me to do, which was to eat well and to make sure I did plenty of water and all those things. So this journey has been a little hard. I guess you can hear in my voice that it's cracking a little bit, but just, go ahead and help me get by it. But most of all, it's all on you. If you get the information, you just need to take the information for what it's worth and move forward. You can live a healthy life after you've had prostate cancer, but you need to do something with it, and that's to live. And in order to live, you have to get out there and move it. So move it.
And that's why we have this special program that Deb has brought you all here today to really kind of talk about the support that you provide for each other as well as for yourself. Because even though you're involved in it, it's still support for you as well. So, Deb, I wanted to for you to just kind of elaborate more on that.
Yeah, with the health griots, this is a group of men, and I have to tell you, I just do what they tell me to do. I make sure that they have their materials to go out in the community, and they are a group of um, 9 gentlemen. 9 gentlemen, right? Nine. There's nine.
I think there's 9.
Yes, I think there's 9 of them who have gone through a journey, who when days when I think it's difficult, when I know on those Wednesdays when they're coming into the office, or that early morning when Mr. Bethay text or call me, that there's more to do, there's more work to do. And the fact that they get together and they go to events such as the one that Mr. Watkins is having on June 28th, 8 to 1.
8 to 1, yes.
At
The 76th Street campus.
At the 76th Street campus, this event that he's having, the fact that you too can come out and see them in person. And this is what is so critical and so important. The support that he gives, that they give to individuals, just by being present. I think even Mr. Hayes, diagnosed at 55, and now he's 85. I often tell the gentlemen when they come in, I need to see their driver's license because I don't believe them how old they are. But when they talk about what they've been through,
yes.
And even Mr. Watkins told me a little bit about his story. I'm just like, okay, there is more to the walk. And Mr. Bethay mentioned how faith keeps them strong. And so one of the things that we do is one of our strongest partnerships, and we do have a faith-based program that we work with, health ministry programs to help build and support health ministry programs in the churches. But this is why programs such as the one that's happening at St. Matthew CME on June 28th from 8 to 1 on their North Campus at 7500 North 76th Street is so important, because this is where people go to gather when they need information. And so this is really key. And I want to lean into what Mr. Watkins is doing.
Most definitely. And Mr. Watkins, I attended last year, and it was awesome. I mean, I saw so many African American men that were there to listen, to hear about all the different topics that you had different providers come in to talk to them about. They had chance to have questions. You had a panel, and then you had information there. And you also had some good breakfast for them too. I mean, that was some good breakfast that morning. I was like, they were eating good. But I really also want to acknowledge that Mr. Watkins, he is on our community advisory board for the All of Us research program. And, he has a journey that he talks about with that too. But I wanted to say that he's heavily involved in the community and believe in the mission of making, or encouraging, I should say, our men to make good decisions with their health. And so, Mr. Watkins, I'm always glad to see you. You are so encouraging to me. So can you just elaborate a little bit about what this event is going to look like?
Yes, thank you, Karen and Deb, for those kind words. Koinonia, our outreach ministry, we are heavily involved in community service, and one of the things we try to do, for the most part, is to serve the underserved, so to speak, in our communities. We work out of 53206, and we make sure that we try to provide the services that are essential to that particular location. There are 3 pillars that we kind of use to strengthen our programs. The first one is the value of partnership. You can't do these things by yourself, and there's no single organization that can meet, the full range of needs for our community. So we work very closely with health systems like the Medical College, Aurora, and several other health organizations, food networks like Feeding America and Hunger Task Force and other locations. And we also work with advocacy programs as well. And that really has allowed us to offer more than just services. We offer solutions as well to some of the needs of the community. We partner and we bring cultural insight, expertise, and resources that help us adapt our programs to meet the real community needs. Another pillow is we tailor our work to the diverse community. And you know, Milwaukee is a diverse city. But if there are also deep disparities as well, especially in the Black and Brown community. And through partnerships, we've been able to customize our reach. And that said, whether it's health screening, trusted spaces that we use, our meal programs, which is rooted in dignity, and also, culturally responsive mental health support. We offer all of that through our Cornelia Family Development Center. And the last pillow is we encourage collaboration, and we've seen some results from what we've been doing, and that's the main thing. Is you can offer all kinds of programs and activities, but if you don't see results from what you're doing, then you wonder what's the real need for it. But some of the results we've seen more families that are accessing nutritional meals regularly, and youth are participating in some of the mentorship programs and educational programs that we're having. Also, we've seen and this is very important, we've seen a shift in trust. And what I mean by that is when we started out, it was a lot of skepticism involved with our programs, but now we see more participation, especially when partners show up consistently and respectfully. So those are some of the outcomes that we're seeing. And what we can say really about this whole thing is community members are receptive to what we're doing. And you can see that some of the programs like what we're having now with the health griots. They're like co-leaders that's in the community that people can recognize and see, and they bring real stories, to the table. I remember when we had our health fair last year, as Karen alluded to earlier. When they started telling stories, and this is before the health griots really, started out, the number of hands that went up when they asked about health screening, when they asked about whether you've had issues with your prostate, half the room raised their hand. So we know that we're getting this information out to the community, and people are responding to what they're hearing. So hopefully, together with what Karen is doing and Deb is doing to sort of bring these things together, we're making a real impact on our community, especially the community of color, because that's where most of our health disparities lie. And if it's not from just neglecting our health, it may be from, like Debo said earlier, not having health insurance coverage and things of that nature that prevents us from having these, problems with our health.
Mhm.
So what we're trying to do with and I'll sum this up, what we're trying to do with our health programs, health fairs and things of that nature, is to bring men together and ask these questions. How can they get these screenings? How can they get some support and some additional help with following up with the things that they really need to do? Because one thing you can say, you only have one health in terms of trying to make sure that you protect that health. So what we're doing is making sure that at least the information is out there to everybody.
Yes, that's wonderful. And I thank you for that, Mr. Watkins, as far as giving information, but also letting people know that there's help out there and you can get resources and information. And I know that Debo had mentioned earlier about, the concern with people not having money sometimes for, or, resources to pay for their health and to get checked. And that's one of the reasons why we have these different health fairs and we have these different events, and you have people that can get testing while they're there and things of that nature, right, Deb?
Yeah, one of our partners is Health Connections with Erica Sinclair, and Erica, I don't know, she's one of those folks that I think she's been cloned because she
Yeah.
is
We had
everywhere.
her on a couple times too.
Yes,
Yes,
yeah.
yes.
And Health Connections offers services. They also offer navigation to care, and their navigation is one to clinics that are or services that are going to be closest. So they themselves are a nurse run clinic, but if you are closer to Milwaukee Health Services or 16th Street or Progressive, they'll direct you there to get a primary care medical home. Now, one of the things I will tell you, listening coming in, to, um, just that one of the issues oftentimes when individuals are underrepresented, um, that part of the issue too is that if we are individuals that are uninsured, often we also have one and two members. So it's not only the issue. I don't have health insurance, but I also don't have the time. So what is so critical are events like the two that we mentioned today. Because if I can go to something and get food and talk to a provider on a Saturday morning, I
Yeah,
so this is why these partnerships are so
most definitely. I know we're getting ready to run out of time. And it's been a delight to really get a diverse conversation today on men's health and hear it from different perspectives, but also hearing your journey, that the men have shared with us today. I want to thank you for coming in and sharing your story with the community. But, one thing that I want the community to do is that you do have control over your health. And it's up to you to make those decisions to talk to your doctor about it, talk to your family about it, and also do what needs to be done. And some of those preventative things are exercise and eating and looking at your environment and your habits of, drinking and smoking and all that stuff. And then also having that spiritual insight that one of the brothers here was just telling me right now, you got to have that spiritual connection. And so all that is so important. And that's why we're here today to share with the community that men's health, take it serious. It's important that we do what we need to do for ourselves. And also when you do that for yourself, you're doing it for your family. You know, no shame in your game. So, this is Karen Dotson. I want to thank all of you for sitting at the table with us today to have an open conversation about men's health. Um, well, you did it. You brought them on in. You brought them on in. Yeah, you brought them on in. But I wanted the community to know that, yes, we do take it very serious, and we want you to take it serious. Thank you for joining us at the table today.